Hi, I'm Dr. Raja Quiller. I'm UK Ambassador and Global Key Opinion Leader in Facial Medical Aesthetics, and welcome to my series of online training webinars. Now I'll be covering a 4-point strategy using hyaluronic acid dermal filler to treat the forehead, eyebrow and temple. The eyebrow should be angulated with 2/3 of the length medially and 1/3 of the length laterally to the apex of the eyebrow. The patient's medial canthus should be in line with the medial hairs of the eyebrow. The patient's lateral canthus should be 1 centimeter medial to the lateral extension of the eyebrow. When addressing the eyebrow, we have 3 options. We can lift the medial end, we can lift at the apex, or we can lift at the tail of the eyebrow. The injection, therefore, will be at the medial part, at the apex, in the temple, or at the lateral tail. Care must be taken when injecting the eyebrow because of the vascular risk that's posed by the supratrochlear artery and the supraorbital vessels. Risk will be lower at the lateral part of the eyebrow than when injecting the medial segment. The target for injection is the retroorbicularis fat compartment, or the roof. This is located in the superior lateral segment of the eyebrow, and this fat compartment will age through life and increase in volume, causing a descent and ptosis of the lateral brow and fat accumulation in the lateral eyelid, with descent of the lateral canthus and heaviness of the crow's feet lines. The injection points, therefore, for eyebrow lift are in the upper hairs of the tail of the eyebrow and at the apex of the eyebrow for angulation and elevation, bearing in mind to be deep in the retroorbicularis fat compartment to generate lift at the desired point for elevation. We can view the lateral brow as being suspended by the temporal fossa, and through aging we see a reduction in volume in the temporal fossa, which deflates the balloon and allows the lateral hairs of the brow to disappear into this hole. When marking the temporal fossa, we palpate for the temporal fusion line and its intersection point with the lateral orbital crest. The inferior margin of the temporal fossa lies at the superior part of the zygomatic arch, the temporozygomatic fusion. The ideal injection point for the temporal fossa is 1 centimeter up and 1 centimeter down in the temporal fossa. We know that the temporalis muscle is thickest at the inferior part and becomes thinner as it ascends superiorly and attaches at the temporal fusion line. There's more vascular risk associated with the inferior part of the fossa when compared to the upper part because of the presence and absence of muscle fibers. Furthermore, the superficial temporal artery ascends in the posterior third of the temporal fossa in most patients, and you can confirm this by a 2-finger palpation to assess the superior and inferior limits of the vessel. Injection at this point must be deep and orientated downwards to the base of the temporal fossa. To get below the base of the deep temporal fascia in the deep temporal fat pad, product will track inferiorly and occupy the temporal fossa, which then restores a superior lateral lift of the brow. Injection at the lateral part of the brow should be deep in the retroorbicularis fat compartment, similarly at the apex of the brow, but always aspirating to negate any risk of intravascular injection of the supraorbital vessels. Now to point number 2, which corresponds to the upper hairs of the lateral tail of the eyebrow The injection plane here will be to the retroorbicularis fat compartment. So through the skin, through the orbicularis oculi muscle, down to the retroorbicularis fat pad, aspirating because of the vascular risk in this area, retaining product at the supraorbital crest, 0.1 cc, mold, and relax. We can see that from position number 1 and 2, temple and the lateral tail of the brow, that we have now achieved an elevation at the tail of the brow with this lateral extension towards the temporal fossa. We can now inject here at the apex point of the brow. This position should correspond at a ratio of 1 to 1.618 from lateral to medial. Again, the injection depth here is through the skin, orbicularis oculi muscle, down into the retroorbicularis fat compartment. Big aspiration to negate any vascular risk. Slow injection of Juvederm Volift, retaining the product in the supraorbital region. Then we take the product and we can stick it into a new location. This skin repositioning is what gives us an apex angulation in the eyebrow. Now let's address the forehead. Traditionally, we've treated dynamic lines in this area with botulinum toxin. Lift the brow and relax. Lift the brow and relax. We know that she has a long forehead, so by treating with botulinum toxin, we will cause further weakness to the vertical fibers of frontalis and give further elevation and extension of an existing long third. Another solution is that we use hyaluronic acid. Inject down at 5mm intervals down onto the Galea aponeurotica to give a mechanical blockade within those deep fibers of frontalis muscle. Lift the brow and relax. Lift. So we inject deep through the skin at the base of frontalis on the Galea, small quantities, molding as we go. Deep, small quantities, and molding as we go. And lift the brow, relax. We can inject deep in the superior part of the forehead because the vessels become superficial. However, in the lower part of the forehead, we must inject superficially in this region. Lift the brow, relax. Lift, relax. Lift, relax. So in summary, treatment of the temple, the lateral part of the brow, the apex point for angulation at the brow, and the forehead, resting in dynamic lines, we can see a number of changes. Firstly, that the union between the frontotemporal skull is now more uniform. We have a superior lateral lifting of the lateral segment of the brow, as well as an apex angulation point at the 5 point 1.618 to 1. In the forehead, we treat not just resting lines, but also dynamic lines. We ask the patient to lift their brow high. You can see lines on the untreated side, but a resolution of lines on the treated side.